Very good morning to everyone, and many thanks to WBAE for this kind invitation for speaking in this wonderful conference. So today I'm speaking about the perioperative role of EZECHO for the everyday assessment in the OR. Now, in the OR, we're used to doing a comprehensive T examination, and depending on the scenario, valvular assessment, myocardial function, systolic, diastolic, and deformation studies, 3D. It's difficult to talk about everything. So I focused on the role of 3D in the perioperative assessment. So I'm primarily going to talk about pre and intra-op, because my subsequent speakers are talking about the post-op part. So in the preoperative part, I'm going to focus on the intra-aortic septum and how to differentiate between planus, thrombus, and vegetations. So the first, this is a comprehensive model of the intra-aortic septum. So this is, we are looking at the intra-aortic septum from the LA perspective. What you can see in the center is the fossa ovalis. I'm sorry. So you can see the fossa ovalis over there. You can see the coronary sinus groove at the back of the LA wall. And you can see the anterior mitral leaflet and the posterior mitral leaflet. I think it's just not a pretty picture. Probably the understanding of how we look at the heart is changing with time. And you can turn the same image from the left atrial perspective. What you see over here is the pulmonary artery on the top. Sorry. We don't have a separate mouse, so probably it's better leave the cursor. Just a moment.
Please come, sir.
So this is the left atrial perspective. I'm scared to touch the cursor. It's going to stop once again. So we can rotate this image and turn to the left. And in one picture, we can see the left atrial anatomy, the intra-aortic septum, the mitral valve, the coronary sinus. You can turn the image as of now, and you can see the pulmonary artery and the aorta. And you turn even more to the right. What you see is again the intra-aortic septum and the relationship of the septum with the SVC, which is as you turn, that's the fossa ovalis. As you turn up, you can see the opening of the superior vena cava. And as you tilt it down with the trackball, you're looking at the IVC. And so for a device closer, for a better understanding of the intra-aortic septum, probably the 3D model is a great tool. So this is a 3D zoom technique. I'm not going to go into it because of the dearth of time. Now, this is a classical ostium secundum ASD, where you can see the relationship of the SVC, IVC, the anteriorly the aortic valve, and the posterior rim. As you can see, all in a composite. And just an example of I hope it works. Yeah. So this is the IVC type sinus venosus ASD, 2D images, enlarged RARV. There's a big atrial septal defect. So bicaval view, you can see the superior vena cava, you can see the large defect towards the IVC side. And you put a live 3D, you can see the fenestrated fossa ovalis and the large ASD. The great part is to change from a live 3D into a 3D zoom, which we will do later, just after this image. There's a prominent eustachian valve. There's a big inferior vena cava and a large sinus venosus ASD. And then you hit the 3D zoom button. Yeah, so that is a 3D zoom of the right atrial perspective, or looking at the intra-aortic septum. Anterior is the aortic valve, superior is SVC, inferior is the IVC, and posteriorly the posterior rim. And that's the fossa ovalis. And you can see a huge IVC type AHD over here. As you tilt it, you look down, there's no rim on the IVC side. And there's a very prominent eustachian valve, and you can see the coronary sinus right over there. So we'll move on because of time issues. So this is one of the great tools for looking at to differentiate between a thrombus, a pannus, and a vegetation. So this is a case where a patient had a bilifted mechanical valve, and there was a stenosis. This is a long axis view of the aortic valve. And all you need to do is turn the image and then increase the elevational plane, and you can see the pannus right over there encircling around the LVOT, very close to the bilifted mechanical valve. So the same image, it's very easy to do it with a full volume, which is the next image. There's a high gradient around 57. So this is a full volume. The green box tells you it's a full volume image. And there's a very interesting tool called the iCrop, and you can use that tool to take up this box, which has a dotted blue line, which is like a torch. As you look towards that blue line, in this case, you're looking at the LA roof. As you turn it towards the LVOT and the ascending aorta, you can see the pannus very nicely. So you adjust the box, and you can see the pannus all around. I'll leave the rest of the video because of time issues. In this particular case, this is purely subjective understanding that you have on the left coronary cusp, there's a big vegetation sitting over there. And this is a short axis view. And a long axis view, the same patient has a vegetation. On the contrary, the next patient has a mechanical aortic valve where there's a huge thrombus sitting in the LVOT very close to the bilifted aortic mechanical valve. And the patient had a high gradient. You can see it on the color Doppler, very strong aliasing across the LVOT and across the aortic valve. So intraoperative assessment, role of 3D in the mitral valve repair. So the first video is very interesting. This patient had a severe MR. The patient came for a MVR, and then it's not working. So there's a huge left atrium, big LV. You can't really assess the degree of MR in this case, although it is eccentric jet, especially in the long axis view. But the etiology of the why the MR was there is not understood with a 2D image with color Doppler. So as you progress and use a zoom mode, there's a huge difference if you tell the exact etiology why the patient was having that bigger MR. So this is an unfaced view of the mitral valve from the left atrial perspective. And as you freeze the ECG, you see on the anterolateral commissure, there's a huge coaptation gap. The rest of the valve is actually fine. So I had to convince our surgeon that it looks like it could be repaired. And this is from the LA perspective. You can turn it, and even from the LV perspective, it's a huge gap. And then we tried to convince the surgeon that I'll show you the color. Yeah. So you can, exactly from that side of where the coaptation failure was there, or rather that gap was there, you can see there's a huge jet coming out, which is the MR. And then we convinced the surgeon for a repair, and eventually the results are like this. This is a live 3D mode. This is a post-mitral valve repair. And you can see in the anterolateral commissure that botched up portion is the area where the surgeon has repaired. And when you put color on that unfaced view of the 3D image, you see a small residual MR. And this is more evident if you actually go forward to see the 4-chamber live 3D with the color. It's a very small residual MR. Patient actually did well. In a 6-month and 1-year follow-up, the patient was actually having lesser MR and did not require warfarin for the rest of his life. So this is a case of assessment of bioprosthetic valve, which got stenosed after 10 years in a 59-year-old lady. And there's nothing great about this, but I think the viewing pleasure, there's a huge LA clot you can see in the appendage. And you can see a lot of aliasing over there. And then if you look at, this is just increasing the live 3D elevation plane. You can see a frozen, almost frozen, highly calcified bioprosthetic valve. And on the zoom image, something very interesting. I'll just pass by. Yeah, so this is a zoom image. So you include the zoom box, not only the mitral valve, but also the tricuspid annulus, the ring. And you can see not only the frozen valve and the left atrial clot, but this beautiful tricuspid annuloplasty ring with a speck of calcium sitting on it. So proceeding to the next one. This is a case where we had a sinus venosus ASD, and we are going to review with a 3D, 31-year-old male with a history of palpitations, enlarged RA and RV, nothing over here apart to suggest. Now this is the bicable view modified. You can see the right upper pulmonary vein draining at the junction between the defect and the SVC. And on a 3D, it's very interesting to just increase the elevation plane. And so this is the SVC, and you can see the part of the defect. And as you turn and increase the elevation plane, you can actually see it much better. So this is the entire ASD, and I will compare with the surgical picture. It's exactly like this, and what you see with the surgeon's forceps is the right upper pulmonary vein. Now, the interesting part in this particular case, although we checked intraop that all 4 pulmonary veins were draining into the LA, but the LA was small, the patient was having hypoxemia, which is 85 to 90% on room air in the post-op period. So the surgeon was very confused. So he did a CT PA, again showed that there was nothing, no problem with the pulmonary veins. So I did an ultrasound. On the lung ultrasound, there were full of B lines, 20 to 30 B lines, suggesting of extravascular lung water. So we diuresed the patient for the next 48 hours. Patient was discharged with a good saturation room air of 90 to 100%, and was the discharge was uneventful. So this is an incidental finding, a patient undergoing CABG who had a moderate MR from before, but we had 2 jets in the intraoperative period, and then we investigated, and the long axis definitely looked a severe MR. I'll show you that. So this is a severe MR over here. So, but the etiology was not being understood with a 2D. When we put the 3D unphased view, you can see a cleft with a coaptation gap between A1 and A2. So leave this over here. So this is a patient where we did a elderly patient. We had a single graft. He had a lesion in the left antridescending artery, and also had a severely stenotic bicuspid aortic valve. So a lot of the times, after the valve is placed, because we have a lot of inotropes on board, these patients would have a high gradient. So it's very important to differentiate between a patient having a patient prosthetic mismatch versus a normal valve. So in this particular case, we did a myocardial deformation study, and it actually showed a very good strain, quite strangely, in spite of a severe aortic stenosis. He had a strain of -19, the global strain, and I'll just show you the bullseye image, if I can. Just cross by. But the anteroanteroseptal area, as the LED lesion was there, was hypokinetic. Now, post-valve replacement, you can see that this is a bioprosthetic valve. This is a deep transgastric view. And as you take the gradient was pretty high, in the range of 28, mean of 28, 32. And of course, this is for the students mainly, that you can actually differentiate by using a LVAT VTI and aortic valve VTI, and then you can do a dimensionless index, and if that value is more than 0.3, then the patient is fine. It's basically because of flow-related issues. The valve is otherwise okay. You can also do effective orifice area calculation, which is pretty simple. So I'll leave it over here. So I think I finished in time. This is my channel on YouTube. All the videos that I showed, it's over here. You can subscribe to it. Thank you so much.
Yeah, fantastic images, Saikat. I could see that you are an artist and making so nice images, and also the presentation were very nice.
Thank you so much.
Very good.
Thank you.
Any thoughts from the audience?
I don't ask any question. I'm just expecting a comment from you.
Nothing to comment about this fascinating presentation. And
thank you so much, sir. Thank you.
And welcome to WBAE and EZECHO, because this is one moment we have been able to invite a lot of cardiac anesthetists to our conference this time, led by Saikat. We have been trying to enroll him in our conference for a long time. Thanks that you are part of the conference now.
It's a privilege, sir. Thank you so much.
Please show us more such images and educate us in times to come.
Thank you, sir.
Keep it up. One question is that while imaging, in general, atherosclerotic vascular disease treatment has revolutionary changes by imaging. Improvement of the anatomy and physiology is well understood.
Absolutely agree, yeah.
And this is now, we are now stepping into the structural heart disease. It is also equally interesting and heartening to see how imaging can help a surgeon, or for that matter, any cardiologist of branch, to assess the perioperative, postoperative, and probably the final outcome of the disease. This is very interesting. A new arena for all of us has opened up.
Definitely a wonderful presentation. Particularly, anesthetists tell a surgeon after coming from the bypass, that how the valves are moving,
right,
and what's the gradient. Though lots of anatropes are going on at that time, so gradient may be to some extent fallacious, but still gives us an idea. And moreover, the tricuspid valve, regarding whether we have to do for anything or we can just leave it. Everything the anesthetist by the PECO tells us, and that helps us a lot for a surgeon to come to the conclusion. Thank you.
Right, sir.
Next speaker, Dr. Shomir Srivastava, early post-op, ECHO.